distinguished director, members of the faculty, ladies and gentlemen, dear students. Education and health are the two most important investments in human capital individuals make. Their economic value lies in the effects they have on productivity. Both education and health make individuals more productive, but education and health also have a considerable impact on individual well-being. It can be safely said that the wealth of nations is to a large extent determined by the educational attainment and the health status of its population. Most of my nearly 20 years of professional life I have devoted to the analysis of issues related to education and health. In this inaugural lecture, I want to review some of the results of these studies. This will be supplemented by the insights and conclusions from other studies in these fields. All of this I will combine to provide an extensive survey on the relation between education and health. I will argue that education and health complement each other. Not only does education affect health, there is also a reverse relation where infant health affects cognitive development and later educational achievements. A second topic in this inaugural lecture is a survey on the evidence on the returns to investments in health. Health economics and the economics of education can be seen as two areas of applied microeconomics. During the past 2 decades, the economics of education and health economics have developed into two fields of their own, with their own research agendas, own journals, etc. Some have argued that these fields of education economics and health economics have bifurcated because of the difficulties in valuing inputs and outputs. There is an easy to observe metric for the returns to education, namely earnings. However, up until now, there's no such monetary metric exist to measure health outcomes. In this inaugural lecture, I aim to bridge this gap again by providing a survey to quantify the effects of health. Compared to the plenitude of studies on the returns to education, research efforts on the returns to investments in health are relatively scarce. However, the available evidence suggests that investments in health have a sizable return as well. Investments in both health and education are largely funded through public means. Public funding typically raises questions how to provide funding for public investments and what's the optimal amount of public resources devoted to these investments. I will argue that knowledge and insight in the social returns to health provide an answer to the latter question. The concluding part of this inaugural lecture will be spent on the former question, namely how to finance public healthcare expenditures. In doing so, I will pay particular attention to the potential reforms of the healthcare financing mechanism here in the Ukraine. The Ukrainian government is intended on reforming its healthcare sector on a European model. According to the order of the President of January of this year, the government intends, and I quote, to accomplish the activities towards healthcare reform and gradual achieving the level of social welfare and protection of the people which is standard for the European countries for the period of the year 2004. Aiming at a similar level of social protection as other major European countries is a praiseworthy objective. However, achieving this aim does not necessarily imply copying social security and healthcare institutions from Western countries, in particular Western European countries. I will argue that in reforming the healthcare sector, Ukraine could benefit more from the experience of countries like Chile and Singapore than to take the European Union as an example. There is an abundance of evidence to suggest that education and health are positively related. Almost all of the empirical studies show that education strongly contributes to a better health. Among others, education reduces the probability of psychiatric morbidity, suggesting a link between life circumstances and development, and psychological well-being in later life. Education has both direct and indirect effects on one's own health, but education may affect the health of one's children as well. A number of studies have looked at the effects of parental education on the health status of their children. A distinction has to be made between the effects of parental education on infant health and the effects of health when children have reached an adult age. One factor that may affect both education level and health status is the educational level of the parents, as I said. Children with higher educated parents are more likely to attain a higher education level themselves. Higher educated parents are better informed about what is good for the health of their children. They also attach a higher value to their children's health. Little is known about the effects of parents' education on the health status of their children. One exception is a study by Lee. This study finds that if the education level of the respondent is not controlled for, health is determined by the education level of the mother, but not by the education level of the father. If the own education level is controlled for, this study no longer finds a relation between parental education and health. If the own education level of the child is not controlled for, it seems that mother's education level has a positive effect on her children's health status at an adult age. Father's education appears to have no statistical significant effect. This latter finding suggests that the effect of parental education does not reflect an effect of genetic endowment. If that were the case, the education level of both parents should have had an effect on the health status. The former finding indicates that the effect of parental education, if any, runs through the educational attainment of the child itself. Higher educated parents have children that attain a higher education level themselves, and higher educated individuals are generally better health. A higher education level of the parents generally contributes positively to health at birth, birth weight, and to the health status of infants and young children. This is important because birth weight and infant health are important for subsequent adult educational attainment. After controlling for father's social class and mother's education, a study by Riches and others find that birth weight was associated with education, with those with a higher birth weight more likely to have achieved a higher education level. Large differences in lifestyle first occur when children reach their teenage years. This coincides with the transition from children from primary to secondary education. It is then that we observe differences in healthy and unhealthy lifestyles between children in lower secondary education and those who attend higher secondary education. For example, in the Netherlands, where I come from, at the age of 15, twice as many young people attending lower secondary education are smoking cigarettes than among students in higher secondary education. Similar findings pertain for alcohol use and the use of soft drugs. A survey by Grossman and Kestner where they present an overview of studies on the relation between education and health shows that higher educated people are less likely to smoke, exercise more, wear seat belts more often in their car, and are more likely to participate in screening programs for breast cancer and cervix cancer. We can conclude from this survey that higher educated people generally have a healthier lifestyle. The only exception is alcohol use. In most countries, the higher educated consume more alcohol than the lower educated. However, many students also show that moderate, but not excessive, alcohol consumption has positive effects on health, labor productivity, and employment opportunities. As a consequence of their unhealthier lifestyle, lower educated people generally report more health problems and make more frequent use of healthcare arrangements. It is striking that compared to the plenitude of evidence on the returns to education, we know so little about the returns to investments in health. Some even question that expenditures on healthcare has positive returns or that healthcare expenditures lead to better health. For example, a well-known study by Illich in the 1970s claimed there's a negative causality. More healthcare leads to dependence, and this in turn leads to a decline in health. And that would mean that more healthcare expenditures would actually be detrimental to people's health. It is difficult to prove that there is a direct causal relation between healthcare expenditures and the health status of the population. However, the question can be asked whether during a period in which healthcare expenditures increased year by year, the healthcare status of the population increased as well. There is a small literature on the evolution of health in Western countries during the past 20 years. This literature does not unequivocally show that the health of the population has improved during these past decades. In a recent study, we analyzed the evolution of health in Great Britain in the 1990s. As a summary measure for health, we used quality of health adjusted life expectancy. It is found that for men, life expectancy at birth in Great Britain increased by 1.5 years, from 73.2 years in 1991 to 74.7 years in 1998. For women, it increased less, by only 1 year, from 78.7 to 79.7 years. However, during the same period, the quality of health deteriorated. For both men and women, self-assessed health status deteriorated between 1991 and 1998. And for both men and women, we find an increase in the prevalence of problems with arms, legs, etc., difficulty in hearing, skin conditions and allergies, heart and blood pressure, circulation problems, stomach, liver and kidney problems, diabetes, nerves and anxiety problems, and depression. Finally, if we adjust the increase in life expectancy for the deterioration in the quality of life and the increase in prevalence of diseases and handicaps, we find that quality of health adjusted life expectancy in Great Britain declined rather than increased in the 1990s. Other studies, however, find that for Sweden and the United States, there is some improvement in quality adjusted life expectancy. So there is mixed evidence about the evolution of health during the past decades. This raises the question whether the resources invested in health and healthcare are well spent. Do the health benefits of healthcare actually outweigh the cost that we make for them? Well, there is surprisingly little evidence on the cost benefits of healthcare. Of course, we know how much money is spent on healthcare, but we hardly know what benefits these expenditures produce. In two related studies, Henriette Maas van der Brink and I have tried to quantify the health benefits of medical interventions. The benefits of healthcare intervention can be determined by calculating the amount individuals are willing to pay for the health improvement obtained by this intervention. Only if the cost of the healthcare improvement is less than the amount individuals are willing to sacrifice for this improvement, the health improvement actually constitutes a welfare improvement. In recent years, cost-effectiveness studies of medical interventions have become a prospering line of research in health economics. However, little or no attention has been paid to the willingness to pay for these health benefits by the population of these benefits that these medical interventions generate. In our first study, we present a new method to calculate the compensating income variation of health impairments. This method uses information from a population sample to determine the willingness to pay to eliminate diseases and handicaps. We apply this method to calculate the benefits of the elimination of migraine headache. The results show that severe headache and migraine reduce quality of life by about 4 to 7%. If we assume that the quality adjusted life year is worth 85,000 euros, a standard assumption in this kind of research, the monetary equivalent of the reduction in well-being due to severe headache and migraine is 270 to 500 euros per month. This compensation increases to about 640 to 1135 euro if we value a life year at 195,000 euro, also an amount frequently cited in the literature as the value of a life year. According to the equivalent scale estimations that we do, for an individual with an average income, the compensating income variation is between 860 and 1230 euros per month. So our findings show that a substantial amount of money is needed to compensate for the loss of life satisfaction or welfare due to migraine headache. If we compare these figures with the cost of medications for migraine and adjust for the fact these medications do not fully prevent migraine, the tentative conclusion is that the benefits of migraine reduction or the elimination of it outweigh the cost of most of these medications. So that has a positive cost-benefit relation. So it's worthwhile to invest in that sort of medication for migraine. In our second paper, another method to calculate the compensating income variation of health impairments is presented. Here we use a specific utility function, known as the Leiden welfare function of income, to estimate the equivalent income variation needed, the amount of money needed, to make someone with a health impairment as well off as someone without this specific health condition. The Leiden welfare function of income is based on the income evaluation question. This question runs as follows. Which monthly after-tax income would you consider in your circumstances to be very bad, bad, sufficient, good, or very good? So individuals have to, for each of these welfare levels, to say what amount of money they would consider bad, or good, or very good. We use the welfare function of income to calculate the equivalent variation of cardiovascular diseases. It's found that for a 25-year-old Dutch male, the equivalent variation of a heart disease ranges from 114,000 euro to 380,000 euro, depending on the welfare level. This is about 10 to 30,000 euro for each additional life year that someone without a heart disease is expected to live over someone with a heart condition. Again, these are substantial amounts of money. The equivalent variation declines with age. As you expect, older people need less to be compensated for heart conditions than younger people, and is about the same for men and women. We find that the estimates of the equivalent variations are generally higher than the money spent on most heart-related medical interventions per quality-adjusted life year, such as bypass operations and open heart surgeries. Heart transplantations, however, seem to be too costly and only beneficial for patients who are young. As the results of these two studies show, the value of health is substantial. The questions that remain, however, is how to pay for the interventions that contribute to better health. The demand for healthcare is potentially boundless, especially as the costs of it are collectively financed. Collective financing of healthcare implies that limits must be imposed on the use of it. This is especially relevant for countries that are strapped for resources for healthcare. In the year 2000, healthcare expenditures per capita, per head population in the Ukraine amounted to a mere $152. This is low, even compared to countries where the economic and social conditions are similar to those in the Ukraine. For example, healthcare expenditures in the Russian Federation were 405 euros per capita. That is more than 2.5 times as much as here in the Ukraine. Western European countries typically spend between 2,000 and 3,000 US dollars per capita on healthcare. Not only in absolute amounts, but also as a share of total national income, expenditures on healthcare are low in Ukraine. Total public and private expenditures on healthcare took up 4.1% of gross domestic product, total earnings, GDP, in year 2000. Whereas the Russian Federation spends about 5.1% of GDP, so of every dollar earned, they spend 5 cents on healthcare. And most Western European countries spend close to 10%, so 10 cents out of every dollar they earn on healthcare. As a general rule, the increase in healthcare spending in rich countries tends to be higher than the growth of GDP, making that healthcare spending as a share of GDP is rapidly increasing. Expenditures per capita, or the share of GDP, gross domestic product, spent on healthcare tells us little, however, about whether healthcare expenditures are too low or perhaps even too high, as health needs differ in scale and nature, and the productivity and impact of public and private interventions and institutions can vary enormously. There's actually little correlation between public healthcare expenditures and health outcomes across countries. However, many people will agree that the healthcare system in Ukraine suffers from a lack of funds, quality, and efficiency. A recent policy paper by the Ukrainian Minister of Health concludes that, and I quote, a sharp cutting down of governmental financing of the health sector without structural reorganizing of the system has led to the situation where a substantial part of expenditures lies on the population to support the existence of efficient system of healthcare. According to this policy document, 51% to 75% of all healthcare expenditures are paid for by private means of the population. And more than half of the population says that healthcare costs have become unaffordable. These are clear signals of the breakdown of the healthcare financing system. For these reasons, the Ukrainian government is currently debating a structural reform of the healthcare system. The Ministry of Health policy papers that I just mentioned identifies 3 strategies for reorganization of the healthcare sector. The first are strategies to ensure the rational use of resources. This entails reorganizing the primary healthcare sector and the hospital healthcare sector. Secondly, the second reform strategy is reforming the financing system and attracting additional resources of financing for healthcare. This includes the introduction of social medical insurance, voluntary medical insurance, and other financing mechanisms. And the third strategy is to implement the use of evidence-based medicine. Here, I want to focus on the second reform strategy, the financing of healthcare, and in particular the introduction of a system of social health insurance. At the outset, let me say that the social health insurance is not a panacea. That is a cure, panacea is a cure for all diseases. Social health insurance is not. With social health insurance, funds for healthcare are separated and thereby insulated from other public health sector expenditures. So they no longer have to compete with expenditure on education, infrastructure, and other public expenditures. It also implies that decision-making in healthcare is at least partly shifted from the government to private or quasi-public institutions. It's shifted from the government to the health insurance organizations. Some might view this as advantages. However, these changes do come at a cost. Firstly, the cost of organization and management of a social health insurance system are probably higher than that of a state-run system. The importance of a well-trained and experienced staff to manage and administrate social health insurance organizations should also not be underestimated. Secondly, a stable system of social health insurance makes high demands on the organizational and management skills and requires careful decision-making by policymakers. In my opinion, three problems stand out when introducing social health insurance. First is the collection of sufficient revenues and distributional issues related to the contributions to health insurance. Secondly, the importance of risk sharing among mostly regional health insurance in order to create stability in the system. And the third important issue is the definition of entitlements. That is, what should we include in a social health insurance package and what should be left to voluntary supplementary insurance. An open and thorough discussion of these topics is necessary before any irrevocable decisions are taken. It should be kept in mind that social health insurance may provide the conditions for the structural underfunding, inefficiency and lack of quality in the healthcare system, but social health insurance in itself does not provide a solution for the problems that the healthcare system in Ukraine is facing. When reforming their healthcare system, many countries look at experiences elsewhere. What has worked in another country is frequently thought to be effective in one's own country as well. This need not always be the case, though. Historical and institutional differences may make the effective institutions or reforms in one country make that they do not carry over to other countries. Like many Central European countries, Ukraine looks at examples from the European Union to reform its healthcare system. It's questionable, however, whether Western European systems would be viable and effective in the Ukraine. Aside from the fact that there are large differences in the way healthcare systems are organized between countries of the European Union, and that the effectiveness of healthcare systems and financing and delivery is, to say the least, questionable in most countries, and most countries, European Union countries, are struggling with healthcare sector reforms themselves in order to make their systems more efficient. The economic and historic differences between the Ukraine and the European Union countries make that Western institutions are unlikely to produce the same effects when implemented here in the Ukraine. Several European countries finance healthcare through compulsory contributions from employers and employees. This social insurance model has proved to be very vulnerable to a combination of rising healthcare costs and a shortfall in contributions resulting from high unemployment and demographic graying of the population. It further appears to be very difficult to impose reforms on these social insurance systems in order to limit the rapid increase in healthcare spending. Perhaps the Ukraine should look elsewhere for inspiration. The experiences of countries like Chile and Singapore might be more relevant and appropriate than those of the European Union countries. Both Chile and Singapore succeeded in creating a healthcare insurance system in a relatively short period of time, about 20 years, just as the Ukraine is now challenged to do. Europe, by contrast, took nearly a century to build its current social health insurance system. Both Chile and Singapore did so when their economy, like the Ukraine now, was not yet well developed and standards of living were relatively poor. Both countries also share with the Ukraine that the reforms of the healthcare sector coincided with a transition towards a liberal democratic form of government. The two countries, Chile and Singapore, also provide interesting comparisons. Whereas Chile has chosen for a highly liberal system with opting out options, the system in Singapore is characterized by tight government controls and compulsory savings for healthcare insurance. In Chile, workers must spend 7% of their taxable income on health insurance and must choose between purchasing public health insurance from the National Health Fund, FONASA, or private insurance from one of the several ISAPRES. FONASA is financed through contributions by workers, transfers from national government, and co-payments by patients. ISAPRE, the private insurance, are mainly financed through the 7% of wages contributed by members and some voluntary payments in excess of the 7% to purchase a better healthcare plan. About a third of the population in Chile has private health insurance. Whereas public insurance premiums are set as a percentage of income, the private insurance companies use risk rating. Private insurance institutions are allowed by law to adjust premiums according to age, sex, and the number of children, number of dependents. Consequently, public insurance is more attractive for people with a high risk of claiming insurance, since the effective price of their insurance is lower in the social sector. This creates a strong self-selection effect against the public insurance. The bad risks are in the public sector and the good risks are in the private sector. This is reinforced by the fact that private insurance beneficiaries are permitted to switch back to public insurance, making the public insurance system a last resort insurer. A typical feature of the system in Chile is that it permits the rich and the low-risk people to opt out of the public health system, thereby eroding the system's solidarity. Conversely, it allows the private insurance companies to cream skim from the public sector enrollees, accepting only people with a low risk of claiming healthcare. The medical savings account system in Singapore is seen by many as an exemplary and innovative system of healthcare financing. Medical savings accounts were introduced in Singapore in the early 1980s. The healthcare financing system in Singapore has two core institutional components: a medical savings account called MediSave and a top-up catastrophe insurance scheme called MediShield. MediShield is a voluntary catastrophic illness insurance scheme to help MediSave members cover hospital expenses resulting from a major or prolonged illness. A third component, MediFund, is aimed at people who are unable to meet any healthcare cost, that is poor. MediFund is basically a national endowment fund to offer charity-style relief. This healthcare financing system is universal, compulsory, and managed by the government. Contributions to the medical savings account, MediSave, are age-related and range from 6 to 8% of monthly income and are shared equally between employees and employers. These contributions are put into a personal but government-managed savings account. A cap on monthly contributions limits the contributions paid by high-income earners. Contributions are tax-free, earn an interest, and form part of one's estate after death. Patients can withdraw money from their savings account when they need medical care. Every ward of every hospital in Singapore charges fees representing at least 19% of total cost, with the government meeting the balance from general revenues. Private hospitals charge patients 100% of the costs. One of the remarkable features of the healthcare system in Singapore is its apparent low cost. Healthcare expenditures in Singapore amount to 3 to 4% of gross domestic product, national income. This is relatively low if one considers that GDP per capita in Singapore is higher than in some Western European countries. Most Western countries with a similar level of GDP per capita spend twice the amount of money on healthcare than in Singapore. This seems to suggest that the medical savings account system is rather effective in keeping health costs low. This surely is something of interest for countries with lower levels of GDP, that are even more strapped for money to finance healthcare. Medical savings accounts are an extreme form of co-payments for healthcare, private co-payments for healthcare. Instead of having to spend some amount of out-of-pocket for healthcare, patients have to dip into their savings account. Co-payments are a way to curb increases in healthcare expenditures and to prevent inefficient use of healthcare resources. However, most of the scientific evidence seems to suggest that co-payments are not very effective in checking increases in healthcare expenditures. According to Shelley Gleed, in a recent paper, cost sharing alone is not a very effective strategy to encourage either appropriate services use or price shopping. Consumers who face greater cost at the margin are not more likely to make medical effective choices about health services use. What, in my opinion, is more important in explaining the apparent low cost for healthcare in Singapore are the strict government controls on healthcare delivery. The supply-side measures intended to cost containment for healthcare in Singapore include controls on the introduction of medical technologies and specialist disciplines in government hospitals, price caps on all medical services delivered in government hospitals, a predetermined rate of subsidy for government hospitals, restrictions on the number of hospital beds, and tight controls on the supply of doctors in the country. What makes Singapore unique is its large government involvement and controls of healthcare delivery, prices and financing, combined with a large appeal to the own responsibility of its citizens, reflected in the large amount of co-payments for healthcare. Apparently, this combination of supply-side controls and consumer cost sharing is an effective way to limit increases in healthcare expenditures. The question, of course, arises whether medical savings accounts are also an option here in the Ukraine. Some of you may argue would argue no, and would point at the pension crisis here in the Ukraine and in other Central European countries in the 1990s, where pension savings were wiped out by high inflation caused by the monetary policies of the government. Adjustments after the collapse of the Soviet system fell heavily on the elderly here in society. They bore a large part of the cost by the erosion of their savings and pensions of the transitions to a market economy. Some may fear that the same could happen with medical savings account, that by loose monetary policies and increased inflations, medical savings accounts are eroded by inflation as well. I don't believe that's such a high risk. Elderly people are not a major economic force to be reckoned with, especially not by politicians, and are also a small part of society, whereas eroding medical savings account would hurt everyone in society and would backlash severely on any government that would try to erode the savings account by raising inflation. Actually, I think a reverse might be the case. I think that medical savings account could contribute to a more stable economic development with low inflation, as no government would want to antagonize its population, its entire population, by eroding savings accounts by inflation. This is not to say, however, that I think medical savings account is very effective. As I've argued before, it's supply-side controls rather than demand-side controls that contribute to an effective use of resources and limited increases in healthcare spending. I've now come to my conclusions. Health is valuable. For most people, their health is the most valuable asset that they possess. People invest time and money to foster their health. Like education, health has large economic benefits as well. better health and a higher education increase labor productivity and individual earnings. I have argued that investments to increase one's health capital are not limited to healthcare alone. Investments in education are also, and perhaps even equally, important for maintaining people's health. Public health adepts are always keen in emphasizing the limitations of healthcare in the production of health. Instead, public health stresses that prevention and health education may contribute even more to population health. I believe that public health should take an even broader view and include all measures that support and increase human capital. This definitely includes education. Ladies and gentlemen, before I finish, I would like to express how very honored I am to stand here today before you and to receive a doctorate of this renowned, international recognized and important university. It makes me also proud to know that so many distinguished people have stood here before me to receive this honor. I would like the President, Professor Maastrichtsky, and the Senate of the University for the confidence they've shown in me. I also want to take the opportunity to thank Professor Irena Griga and the people from the School of Public Health and the people from the medical faculty who are also present here today. I want to thank in particular Irena for her friendship and for the pleasant and productive way that we have been working together during these past years. Irena, it's very gratifying to be able to work with you and all the others who are involved in the new master program in healthcare management here in Ukraine. We at Maastricht University are very pleased to see the program in healthcare management which has started yesterday, and that is being based on our successful program in economics policy management at Maastricht University. Today, I also hope that we are able to sign a contract between our two universities to write down our mutual commitment for further collaboration and joint degree programs in healthcare management and organization. In a way, the development of the new education program on healthcare management combines two central elements in my lecture today, namely education and health. Governments in all countries face difficult questions in the allocation of resources spent on healthcare. What's the optimal amount of resources spent on healthcare? Should one spend more on healthcare or rather on publicly funded activities like education? And finally, how should healthcare systems be organized and financed? In this inaugural lecture, I have attempted to address these questions. A lot remains to be done, however, before any definite answers to these questions can be given. This is why the new master program in healthcare management that has started yesterday at this university is so important. The master program will educate young people who are able to analyze problems in healthcare organization, management and financing on their own, and who will be able to contribute as a manager, a policy maker, or as a researcher to the improvement of the efficiency and the quality of healthcare here in Ukraine. I also hope that the master program will become the focus point of more research on the organization, management and financing of public health here in Ukraine. Good policy initiatives are always based upon sound scientific evidence. Both for the viability of the master program itself and for the improvement of the quality of policy making, it's important that a good research infrastructure on public health is established. As an honorary professor at your university, I hope to be able to contribute to that. Thank you very much.
Thank you, Professor Groot. And we have approximately 25 minutes for questions, so you can raise any question regarding the topic of this lecture, please.
Роман, the master program of public health school. On your opinion, in how many years can the Ukrainian new public health system be built?
Most Western European countries took about a century to build this current system. So I think you can and you should aim at doing it a little more quicker. But on the other hand, I think it's frequently underestimated how much time and effort it takes, and also how much resources and also in people it takes. How you have to train and have to have sufficient numbers of trained managers and administrators to be able to run this system. It's not just that you have to write a new law on health insurance and then that's it. No, actually most of the work comes after that in managing and organizing this system. And that's why you need good people for. And actually I think the people who are trained in the master program will or may become the core staff of these new insurance companies. But it takes time in order to train these.
What is your explanation of education? So just mean some academic knowledges or some moral principles which also influences on philosophy of life and health life of people?
Well, I think if you look at academic education, I think that academic education provides you with basically with knowledge on the one hand and academic skills on the other hand. And of course academic skills you have to apply to a certain field, certain discipline area. But I think the most important, most valuable contribution of a higher education is how it develops your academic skills, your writing skills, your skills to express yourself verbally. That I think is what you will find later on in life that is most valuable to you. Of course, you have to apply that to certain fields, and I guess also the knowledge that you acquire also brings into you some sense of the moral values that underlie this knowledge and these insights that you obtain. I think individuals pursue a higher education, of course, first of all, because they think they themselves may benefit from it, but also society at large benefits from these investments. It's also that you are able to do something meaningful and something worthwhile to society with the skills that you have obtained here at this university.
Thank you. And another question. So, in your presentation, there was a statement that better educated people are in better health, and so do you have some experience of research if investments in education they influence situation on healthcare system, or are you going to provide such researches in Ukraine or somewhere in any country?
Well, we did some research on this ourselves, which shows that more education makes people healthier, but there's also, well, there's more evidence around. For example, one striking example is if you look at developing countries, African countries, for example, where you see that usually when you educate people, it does more to their health than if you provide health care for these people. There you see the lower level, but also in more advanced societies, you see that education makes that people are more aware and more informed about health risks and are also more willing to pay for eliminating these health risks.
If you mention the research about the cost benefits of investment in health, but health is not kind of homogeneous.
No.
You can divide health into prevention,
Right,
into
yeah.
treatment and care. So in your opinion, Is there a rationale for this disaggregation? And can you provide any kind of rough data of proportions between these three areas?
Well, you see, it's not prevention and healthcare is not two isolated or separate affairs. You see increasingly so that prevention and healthcare are become entwined. Take, for example, all the genetic screening programs that are part of prevention programs, but that do involve some medical intervention. So that's at least an area where you see prevention and healthcare getting quite close to that. Also, I think if you look historically, then you see a shift in the relative importance of prevention and healthcare. At least you can say that in the 19th century, and also I think for large parts of the 20th century, the main health benefits have come from preventive measures, sanitary measures, for example, vaccination programs that have contributed tremendously to improvements in health. That has, of course, gradually worn off, making, on the one hand, that the increase in life expectancy is slowing down. But on the other hand, that the relative importance of medical interventions might have increased in the past years. Especially so because you see in the medical field that because of breakthroughs in medical technologies, many diseases that in the past were mortal disease where people died have now become chronic diseases. Take, for example, AIDS. The AIDS, because of new medical technologies, AIDS has become not a chronic disease, which means that actually life expectancy for AIDS patients have increased tremendously, but also the cost of treatment for these patients have increased quite substantially. So I think it's not, well, I think it's prevention in healthcare are becoming more closer, less separated than they were in the past. And also I think if you look over time that there are differences, there's a change in the relative importance of prevention and healthcare in contributing to better health.
According to a speech that Ukrainian government has to build new healthcare system. But to my mind, our country has good base and some old traditions, and our system needs only little reforming. And what is your opinion?
Well, to begin with, the statement that the current healthcare system needs reforming is not something I myself thought of, but it's the position of the Ministry of Health, who think that some changes have to be made. On the other hand, I think very few people doubt that, like I said in my lecture, that the Ukrainian system suffers from a lack of funds. Quality is not always, sometimes leaves something to be desired, and also the system is not very efficient. One example, Ukraine has relatively many people working in the medical field compared to other countries. The number of physicians to the number of people, the number of population is relatively high. So maybe another way of allocating resources may increase, for example, also the status of the medical field by, for example, having fewer physicians but better paid for physicians. We also know that payment schemes can contribute to better quality healthcare delivered by physicians. So if you pay them more but have maybe fewer physicians, that may be one simple way of increasing efficiency in the system.
Don't you think that health of people has a direct connection with the environmental situation of place where they live? For example, quality of public utilities, quality of water, and problem of waste. What do you think about?
I think you're absolutely right. I think that's an area where still large health benefits can be here in the UK can be obtained by improving sanitary conditions, maybe also informal health education for people. But I think improving the environmental conditions is, for example, there are quite different areas. There was a study done in the Netherlands about the health risks of pollution for people living next to highways, pollution by emissions by cars, and it was found that, for example, the prevalence of asthma among children living close to highways was, I think, 2 or 3 times higher than among children living further away from highways. And also, this study showed that living near a highway or a traffic-intensive part of the city has an effect on mortality rates. So reducing emissions from cars, for example, I think is one way of improving environment, but also improving health of people.
Thank you. I can tell that I didn't understand your answer. So, can you tell how precisely many years we need to build our insurance system? Because even 90 years is too long for me. And it reminds me one anecdote from 1986 years, Chernobyl year. The Armenia radio asks, how would Kievite live after Chernobyl disaster? The answer is, they will live very bad, but not so long. But you know, we are alive and kicking, and let me start the ceremony awarding Professor Groot with the title of Honorary Professor of Kyiv Academy. I invite first Vice President to the floor to assist me and other people. Let me quote the decision of our Senate. Diploma number 15. The University of Kyiv Academy, with approval of the НаУКМА Senate, protocol number 35, June 10, 2004, conferred the title of Honorary Professor of НаУКМА on Вім Гроот in recognition of his distinguished scholarly achievements.